resident in our department, a very dynamic person. She'll be talking on approach to case of recurrent pneumonia, a KGMU experience. I welcome you, Dr. Akanksha.
Thank you, ma'am. Good afternoon, everyone. I will be talking on topic approach to a case of recurrent pneumonia and KGMU experience under guidance of Professor Srivastava, ma'am. I will discuss this under following headings: introduction, approach to a case of recurrent pneumonia, our KGMU experience, and two different case scenarios seen in our department. So starting with definition of recurrent pneumonia. Recurrent pneumonia is defined as at least 2 episodes of pneumonia in 1 year or 3 episodes in any time frame with intercritical radiographic clearing of densities. Incidence is approximately 7.7 to 9% cases of community acquired pneumonia. The main challenge in diagnosis of recurrent pneumonia is how and when to decide for investigations. Now, starting with approach to a case of recurrent pneumonia. When should we investigate the patient for underlying etiologies? Before proceeding for further investigations, we should always look for the risk factors which predispose the patient for recurrent chest infections. Since upper respiratory tract infections are common in childhood age group, therefore, before proceeding for further investigation, we should always rule out URI. It is also very important to differentiate between recurrent pneumonia and episodic illnesses like asthma, because an asthmatic child can also present like a bronchopneumonia and will be treated for recurrent episodes like asthma. So therefore, it is always important to differentiate recurrent pneumonia from episodic illnesses like asthma. मूव नहीं कर रहा है. Now, how to proceed for evaluation? Proper history and examination is the key to reach to our underlying etiology. During history taking, we should always ask about the age of onset of the symptoms. Earlier the age, more is the possibility of presence of any structural anomaly like tracheoesophageal fistula or any genetic disorder or underlying primary immunodeficiency disorders. Details of each episode should be recorded properly. Any past history of previous hospitalizations, recurrent infections needing hospitalization and prolonged IV medications, and other associated complications should be recorded. Perinatal history should be taken. We should ask about whether the patient was term delivered or preterm delivered, and history of prolonged intubation should always be taken because preterm delivery and prolonged intubation is a pointer towards bronchopulmonary dysplasia. Family history of tuberculosis should be taken. Family history suggestive of any underlying immunodeficiency disorder should also be taken. And exposure to environmental pollutants should be taken, as presence of indoor, outdoor pollutants or tobacco smoke can predispose the patient to recurrent chest infections. After taking history, physical examination should be done, and the aim of our physical examination is to document presence of respiratory added sounds, to localize the site of infection, and to detect any underlying etiologic factor too. Now I will discuss some key features which we should record while taking our history. So starting with congenital heart disease. To rule out presence of congenital heart disease, we should always ask the parents about history of sucrose cycle, that is becoming easily tired, decreased intake of breast milk, excessive sweating while feeding, history of fatigue, history of not gaining weight properly, history of rapid breathing, difficulty breathing, and history of rapid heart rate. On physical examination, we should always look for the features of congestive heart failure, which will be a pointer towards congenital heart disease with increased left to right shunt and increased pulmonary blood flow. On auscultation, we find presence of murmur and other signs suggestive of cyanotic heart disease like presence of cyanosis on skin, lips, fingernail, etc. If we are suspecting gastroesophageal reflux disease in a patient, then we should ask mother about the feeding pattern of the infant, whether while feeding patient get irritable, there is frequent vomiting after feeding, or there may be sometimes episodes of choking or cyanosis during feeds. Baby may also have refusal to eat, and there may be presence of an abdominal pain or colicky behavior. To look for cystic fibrosis as an underlying etiology, we should always ask history related to other symptoms seen in cystic fibrosis related to pancreatic exocrine dysfunction like history of greasy stool, diarrhea, history of not gaining weight, failure to thrive. And these patients also have history of recurrent chest infection. In physical examination, we may find clubbing, wasting. On auscultation, there may be presence of creps or wheeze and other features suggestive of malabsorption. To rule out primary ciliary dyskinesia as a cause of recurrent pneumonia, we should inquire about history of recurrent persistent wet cough, recurrent rhinitis, recurrent ear discharge, and history of neonatal respiratory distress, history of hearing loss. And on X-ray or physical examination, we may also find dextrocardia. Bronchopulmonary dysplasia can also predispose the infant to recurrent chest infections. To rule out bronchopulmonary dysplasia, we should always ask about the time of delivery, preterm birth, prenatal factors and maternal complications like preeclampsia, maternal smoking, IUGR, and postnatal factors like history of prolonged mechanical ventilation. All these factors predispose the baby to develop bronchopulmonary dysplasia, which in future course may be a cause of recurrent pneumonia. When should we plan for immunological workup? If there is previous history of persistent diarrhea, any deep-seated severe infections needing hospitalization and prolonged IV drug administration, history of abscess, balls at other sites, etc. And if there is a positive family history suggestive of primary immunodeficiency disorders. Recurrent pneumonia can be classified as unilobular or multilobular based upon the lobes of the lung involved. As we all know, right lung is divided into 3 lobes by 2 fissure, horizontal fissure and oblique fissure into superior, middle and inferior lobe, and left lobe is divided into superior and inferior lobe by oblique fissure. So therefore, recurrent pneumonia can be unilobar pneumonia and or multilobar pneumonia. Causes for unilobar recurrent pneumonia can be a foreign body aspiration or any congenital anomalies like vascular ring or congenital web. So to rule out that, we may go for a bronchoscopy, and if bronchoscopy is also normal, then we should proceed for CT chest. Causes of multilobar pneumonia can be recurrent pneumonia with immunodeficiency and recurrent pneumonia with normal immunity. Recurrent pneumonia with immunodeficiency can be either primary immunodeficiency disorders or acquired immunodeficiency disorders like HIV infection. Recurrent pneumonia with normal immunity with multi-lobes involvement can occur in patients with congenital heart disease, in patients with recurrent aspiration, patients with allergy or asthma. Post-infective bronchiectasis will also lead to recurrent chest infections, any structural abnormality, or mucociliary deficiencies like primary ciliary dyskinesia or Carter-Jenner syndrome. So which diagnostic approach should we follow for recurrent pneumonia? Actually, there is no evidence base to inform the clinician of the optimal timing of investigations or the optimal sequence of the diagnostic workup in children with recurrent pneumonia. I will be discussing the diagnostic approach which we carried in our study on recurrent pneumonia. After taking history, physical examination, and first-line investigations, along with chest X-ray, we excluded patients of pulmonary tuberculosis and foreign body aspiration in our study. If history suggestive of underlying cardiac disease were present, then we went for 2D echo. And if any history suggestive of structural anomalies which we can see from X-ray like diaphragmatic hernia, diaphragmatic eventration was present, then for further delineation of that underlying etiology, we went for ECT thorax. If none of these causes were present, then if there was suspicion of underlying immunodeficiency disorder, then immunodeficiency workup was done, which includes immunoglobulin profile level, B subset, T subset analysis, and dihydrorhodamine test for granulomatous diseases, and HIV ELISA to rule out HIV infection. If there was high suspicion of cystic fibrosis, then sweat chloride test and mutations for cystic fibrosis was done. If there was suspicion of GERD or recurrent aspiration, then GER studies, barium swallow, and bronchoscopy was planned. If we get no clue from history and examination, then at last we can go for CT chest bronchoscopy or primary immunodeficiency test. In our study, 32 patients fulfilled the criteria for recurrent pneumonia, and underlying etiologies found were: majority of the patient had congenital heart disease, which contributed about 43.7%. Recurrent aspiration in the patients of global developmental delay or cerebral palsy due to velopharyngeal insufficiency was present in 18.8% patients. In structural anomalies, we were able to find diaphragmatic hernia, diaphragmatic eventration, and tracheobronchus. Cystic fibrosis was found as an underlying etiology in one patient. Chest wall deformity leading to recurrent chest infection was found in 2 patients. When compared to other study conducted by Lodha et al. At AIIMS New Delhi, our diagnosis rate was similar to that conducted by them, and underlying etiologies which they found were also nearly similar, that is lung and airway anomalies and diseases, aspiration syndromes, congenital heart disease. Cystic fibrosis, they excluded from recurrent pneumonia, and they found it as a cause of persistent pneumonia, and 7 patients of PCD were found in their study, and pulmonary tuberculosis was excluded by us. They found it as a cause of persistent pneumonia, and immunodeficiency disorders were present in 15.7% of their patients. We sent samples for 4 patients for PID workup, but none of them came out to be positive. These were the studies conducted in other parts of the world by Hoving et al. In Netherlands, Oed et al. In Canada, and Mustafa et al. In Egypt, and they also found that majority of the patients of recurrent pneumonia have an underlying etiology. So conclusion from these study results were the majority of the patients with recurrent pneumonia have an underlying etiology. Diagnosing underlying genetic disorder or any structural anomaly or immunodeficiency disorder timely can have significant impact on patient survival. Treatment of RP is mainly to control the current infection and treatment of underlying etiology. Now I would like to discuss two case scenarios in brief, which was seen in our department. This 5-month-old male presented with chief complaint of on and off fever since last 4 months, difficulty in breathing on and off since last 4 months, failure to gain weight since last 4 months, and lose stool since last 5 days. Past history was very significant in this patient. Patient was admitted at day 10 of life in view of fever and respiratory distress, where he was given antibiotics for 10 days and was then discharged. History of repeated hospitalization in view of respiratory distress was present at 2 months of age, 3.5 months of age, and 5 months of age. Family history was also positive in this patient. Patient was a product of second-degree consanguineous marriage, and history of sibling death was present. So based on the physical examination, patient was sick looking and severe wasting was present. On auscultation, bilateral fine crypts were present, and on palpation, hepatomegaly was present. So based on history and physical examination, we kept a differential diagnosis of immunodeficiency disorders and cystic fibrosis. Chest X-ray was done. Chest X-ray of this patient was suggestive of bilateral pulmonary infiltrates along with finger in glove appearance suggestive of mucoid in bronchus. CT thorax was also planned in this patient, which was suggestive of multiple ground glass opacities along with some fibrocavitatory changes, and radiologists reported this as consolidation with cavitation, query, infective etiology, query, fungal infection as per Giloma. We planned a PIT workup for this patient and it came out to be severe combined immunodeficiency, SCID, type T negative, B positive, and NK cell positive. Coming on to other case, this patient presented with complaint. This 5-month-old male presented with complaint of fever on and off since last 3 months, wet cough since last 3 months, and difficulty in breathing on and off since last 3 months. There was history of an ICU admission for 5 days in view of respiratory distress. Patient was discharged at day 6 of life and was apparently asymptomatic till 2 months of age. Family history: elder sibling was diagnosed with cystic fibrosis at 1 month of age, and that case was discussed by Shaili Avasthi ma'am. Physical examination: on inspection, patient was sick looking, average build, subcostal retractions were present, respiratory rate was increased, and on auscultation bilateral wheeze was present. So since there was a clear-cut history of elder sibling having cystic fibrosis, so first differential was kept that only recurrent pneumonia caused cystic fibrosis. CFTR gene mutation of this patient also came out to be positive and suggestive of heterozygous 3 base pair deletion in exon 11 of CFTR gene. So therefore, my take-home message is recurrent pneumonias usually result from deficiencies in the local pulmonary or systemic host defenses or from underlying disorders that modify the lung defenses. Detailed history and physical examination are essential for planning investigations. After ruling out tuberculosis and congenital heart disease, the most common condition predisposing to recurrent or persistent pneumonias include aspiration syndrome, structural anomalies, cystic fibrosis, and immune deficiencies. Thank you.
Thank you so much, Dr. Akanksha, for that beautiful presentation. I would request the audience if they have any questions. Okay, so with that, we come to the end of our session and also our webinar series. I would like to take this golden opportunity to thank all the speakers, faculty, and audience for attending this and making it a grand success. I extend my heartfelt gratitude to our respected head of the department, Professor Sherry Avasthi ma'am, for conceiving the idea of this webinar week and guiding us throughout. I thank you, ma'am. Once again, I would like to thank one and all wholeheartedly for being with us and making it a success. Thank you.
Thank you very much, Dr. Arpita, for conducting it so well, and to each and every faculty of my department who gave a wonderful discourse during these 6 days, and the 4 senior residents, Dr. Rajiv, Dr. Sakshi, Dr. Ashutosh, and Dr. Akanksha. And I'm sure these are our future. They will be our future pediatricians, future faculty somewhere. We should continue with all this every year so that the academic ambience of our department continues. Thank you all very much for staying with us. It's very happy to see 80, 90 people with us. Thank you, Archana ma'am. I saw you just now. Thank you all. And with this, we close. We are trying to put the recordings on YouTube and creating a departmental YouTube channel. It's taking us some time. So once we do that, we will share the link later with all of you. It will not be available on the Zoom cloud because we don't have so much space and the space is exceeded. Okay. Thank you all.